Is IR a clinical specialty? This is a good question. This sort of comes up from time to time, this question of, is IR clinical enough? And it always feels like, at least recently, the last 5-10 years, that we're always having to prove ourselves as being a clinical specialty. And my take on this is pretty straightforward. When has it not been a clinical subspecialty? It's always been taking care of patients. So it's always, and again, in my definition, been clinical. But you got to realize there's different levels of being a clinician. There's different ways to do it. All right. And again, you have to decide your level of involvement. Now, first of all, let's define clinical. The concept of clinical, does it literally mean that you have a clinic? Do you have to have a dedicated clinic space? Should it be located in a building with other medical clinics? So, for example, does IR, in order to be clinical, does IR have to be stationed next to an internal medicine clinic and an OBGYN clinic and a GI clinic? And then in between all those, we have the IR clinic and we have the IR hallway. Is that what clinical means? Does clinical mean that you have patient exam rooms with a exam table and a computer and otoscopes, and we have a little flip tab on the outside which says the IR doctor is in? Is that what clinical means? The patient has to have their vital signs taken. The patient's checked in by an MA. Was that what clinical means? Do you have to be wearing a shirt and tie or a dress or a white coat? Do you have to be wearing non-scrubs to see the patient? Is that what clinical means? Again, I think there are elements of this in clinical medicine, but again, we know this is not true in the sense that we don't need these things to be clinical. In fact, some good things about coronavirus has been that we have seen the transition of what clinical medicine is. I mean, clinical medicine could be just what I'm doing right here, pulling out a phone and talking to someone via video. That can be clinical medicine. You can bill Medicare for a clinical visit done exactly in that manner, where you talk to a patient via video chat and discuss medical problems. You discuss ICD-10 diagnoses and you talk about ways to manage them, and that's clinical. So again, we gotta stop thinking that clinical means you have a dedicated IR or other clinic, you walk into a room, you put your stethoscope on the patient, you listen to their heart and lungs. Yeah, there are elements of that in clinical medicine, but that doesn't have to be clinical medicine that way. You can practice many different ways. You can practice talking to patients using a cell phone. You can practice clinical medicine talking to them on the phone. Okay, you can talk to them when they're down in the procedure suite for their procedure. You can continue the conversation after the procedure. You can round on them after the procedure. You can not round on them after the procedure. You can check in with the nurse after the procedure by calling the floor and talking to the nurse. You can voice Sarah the nurse. So again, there's so many different ways to be clinical in IR, okay? Your version of clinical doesn't have to be my version of clinical. That's the main issue, really. You have your definition of what you think clinical is. It doesn't have to be the other person's definition, and let's not make this my version or nothing, right? There are IR doctors that practice a version of IR that probably has been going on since the 80s, 90s, and early 2000s, where the patient comes down, they get the procedure done, the patient goes back up. And again, for certain circumstances, that works, okay? And there's nothing wrong with that. Really, there's nothing wrong with that. There's other ways to practice, though, where you see the patient before the procedure, you do the procedure, you see the patient after the procedure, you bill procedural visits, you bill clinical visits, you keep the patient your cell phone, you keep in close contact with them, you manage post-procedural complications. That's another way to practice. Again, nothing wrong with that either. The fun thing about IR, the reason I think that it's fun and interesting and it keeps people engaged and it keeps people coming into the field, is that it's a little bit of how you view it, right? It's kind of, what do you bring to the table? How do you want to do it? You decide your level of involvement. You decide how clinical you want to be, and you decide how to use technology to be as clinical as you want to be. I like spending a lot of time on the phone with patients, chatting with them on the phone. I'm at a station, I'm reading cases, I need to take a break, I'll follow up on some patients, I call them by phone, chat with them on the phone. You'd be surprised how many of these patients are sitting at home waiting for somebody to call, and they just need to release some of those anxieties, some of those feelings, some of those frustrations on somebody, and talk to a doctor. Doctor is here, right? Doctor's here to talk. Doctor's here to be clinical. Doctor is here to hear what you have to say, and the doctor will document that note and place it in Epic, and if it's billable, it's billable. If it's not, it's not. It's not a big deal to me, but we are here to provide good care at the end of the day, whichever way possible. Let's not create the narrative that IR wasn't clinical and is now trying to be. Let's create the narrative that, well, we already know, IR has been and will always be a clinical specialty because we literally take care of patients, and that's what clinical means. I'll leave it at that. Surel MD.